Good morning, dear chairs, dear audience. I would like to talk you about my PhD topic. The title of my PhD is The Role of Mental Health Status in Pediatric Inflammatory Bowel Disease. My name is Dávid Horváth. I am a pediatric gastroenterologist at Bethesda Children's Hospital, and I am a first-year PhD student here at Semmelweis University. I treat patients also with inflammatory bowel disease in my everyday practice, and I see that among my patients, among the pediatric gastroenterologist patients, they have to face the most difficulties and challenges in their everyday life because of this chronic burden. So my vision is that despite their illness, they will have excellent quality of life. To achieve that, my mission is to identify every kind of psychological interventions which can help to make better their quality of life and the disease outcome. In this year, or last year, I have started two projects. One is to investigate the effect of psychological interventions, and another is the effect of mood and anxiety disorders of the disease outcome. My first project is done by a systematic review and a meta-analysis, and I want to show you the background why it is important to talk about the psychological factors in this disease. We know that the incidence of inflammatory bowel disease is increasing worldwide, which is very important regarding a pediatric and adolescent population, because 25% of the disease starting at this period, which is a very important period for psychosocial development, the age when these children and youths go to school and they want to make friendships and relationships, and they can study and go forward for educational move forward, yes, and by this illness, by the flare-ups from the disease, they miss the school and they can't go out with their friends. So it have a large psychosocial impact on them. We know from cohort studies that the patients with pediatric onset IBD has a 15% increased risk of depression later, and we know that the youngest the patients, the highest risk of work disability is presented later. The current guidelines are focusing mainly on the pharmacological and surgical approaches, but lack of psychological support or guidance on that, what to use, or does it matter to use them anyway, is lack. So let's talk about what kind of psychological interventions are spread, or what kind of psychological interventions can be done among these patients. Their psychological intervention is a heterogeneous group, which means that there are different schools and different grouping for that. Three types of psychological intervention is used among IBD patients. Mostly one is cognitive behavior therapy, one is mentalness-based cognitive therapy, and the third is hypnotherapy. The effect or the mechanism, how does it affect, is based on the, I can say, three ways. One is that they can make the quality of life better by themselves. The second, if the patient has comorbid depression or anxiety, they can be treated by that. And the third, through the psychoneuroimmune pathway, which includes also hypophysis, pituitary adrenal gland axis, and also autonomic nervous system and immune system. It can have anti-inflammatory effect on the disease, so it can make the disease outcome better. Our aim is to understand the impact of psychological interventions on disease outcome and the quality of life in children with IBD. Our clinical question that does psychological intervention change the disease activity and quality of life of pediatric IBD patients compared to standard care? We put our question in the PICO framework. We compare standard care with psychological intervention to standard care. We have psychological and clinical outcomes, and our hypothesis is that psychological intervention increase the quality of life and decrease the disease activity in pediatric IBD. If our hypothesis is true, it should be implemented in the clinical guidelines, and they should be used in every clinic where treat pediatric IBD patients. We have done systematic research in 3 databases, and we found about 9,000 articles, and from that, after the full text selection, we have 19 articles. We are currently doing our data extraction. We plan to finish it by next week, and after that we move forward. So we have results. I have to move on to my second project, which is a multicentric prospective observational study with the acronym EMPATHY. It will investigate the depression and the mood disorders, the effect of them on disease outcome among these pediatric IBD patients. This is an important topic because by receiving the diagnosis of this chronic disease, the children and the family is affected negatively, and we see that the diagnosis in children and young increases their likelihood of facing mental health concerns. The prevalence of depression could be 33% in this population, and we know from adult studies that by receiving the diagnosis of depression who has IBD, the treatment escalation and the disease outcome is worse. We see that 1.4-fold risk of surgery, risk of flare, and treatment escalation is presented in this population. But our lack of data among pediatric patients, so that's why our aim is to investigate the role of mental health status on clinical outcome in newly diagnosed pediatric IBD patients. We put our question in a PECO framework. We would measure depression and anxiety at the diagnosis and after the induction treatment, and we would follow up the patients later, but first we want to measure in the first period of when they receive the diagnosis. And our hypothesis is that the mood and anxiety disorders affect clinical course negatively in pediatric IBD patients. So if our hypothesis is true, at the beginning when they receive the diagnosis, psychological screening should be implemented in the care of these patients. To summarize my projects, we would like to finish the first project in this autumn and the second project next year. So I would like to thank you for attention with a quote from Seneca: "If a man knows not to which port he sails, no wind is favorable." Thank you for your attention.
I wanted to ask about how you deal with parents in these situations, because usually pediatric patients are not independent of their parents, and are they involved in these psychological interventions, or are they asked about what they think?
Yes, in our first project with the full text, we see that these psychological interventions are in some articles they doesn't focus just on the patients, the pediatric or youth, but they are focused also on the parents, and there are some diet sessions, but there are some sessions for the parents also. So it is an important topic that pediatric patients are not alone in this situation, and we have to, I can say, treat the parents also with this kind of interventions.
I would like to ask that, what is your clinical experience, that is it hard to give advice to the adolescent to find a psychologist?
It depends, I think, patient by patient, but in my small experience, I could say, because I didn't perform a survey on that, among my patients, if we talk about that and they understand that they can make their illness better, and they know that it's a chronic condition, and I see that mostly all the families want to do anything just to improve. They want to change the diet, but sometimes it's not necessary. They want to give probiotics, but sometimes it's not necessary, and we talk about other possibilities, and they understand that it is an important topic, and there are sometimes then when they ask, is it help or not? So I think in pediatric population it's well accepted.
I would like to ask you, how are you comparing different psychological intervention? Are there uniform scales for that? Thank you.
Thank you for your question. Yes, we faced this question when we did this full text selection, that there are different scales, mainly for the psychological scores, but we found articles which shows the correlation between different scales. So I hope we can compare that. Clinical outcomes are unified or they are standardized, so we don't have this problem in that case, but psychological measures are very widespread.
Is there like a group of pediatric gastroenterologists, like a link, if you're planning to go multicentric with this study?
Yes, fortunately we have a good collaboration also in Hungary, because pediatric gastroenterology is not a big specialty, so it's a good connection, but also in Europe we have a European society in which there is a group named Porto Group, which has a good collaboration, so I hope that we can reach many of them, because my supervisors are well known in this society, so I hope to have many patients for this second project. Thank you.
In the IBD patient population, are there any studies that these psychological interventions are beneficial in adults? And
yes.
How do they compare to the pediatric population? Is it more beneficial to start early?
We have more data on adults, but we want to focus now to differentiate a bit the pediatric populations. But in the adults, we see that they can be used in everyday life. So they have many data, and we just discussed in the beginning which study to include, because there are some age differentiation. Maybe you've seen that we choose to select patients till the age of 25, which is not a pediatric population in the Hungarian sense, but we see that this group is adolescents and young adults. It is a different group from the others. So I think, to answer your question, it's best if we face this difficulty to start as soon as possible, because the disease won't be solved, unfortunately, but they have to live with that.